Hello, everyone. I'm really excited to welcome you to today's webinar, where we're going to get a CEO's perspective on the value contributions from enterprise-wide AI in radiology and beyond. I'm Nicola Emery, and I'm ADOC's Marketing Director for Europe, and I'll be your moderator today. With me, I have Marc Noppen, the CEO of Universitair Hospital Brussels, and ADOC's VP of Europe, Alex Boemke. Marc and Alex, could you please briefly introduce yourselves? Maybe we'll start with you, Marc.
Okay, good afternoon, everybody. I'm Marc Noppen. I'm a pulmonologist by background. I've been a clinician for almost 20 years, and now I'm serving as the CEO of UZ Brussel, the University Hospital of Brussels, since 2006.
Wonderful, thank you. Alex.
Yes, also good afternoon, everyone. My name is Alexander Boemke. I'm the responsible for the ADOC business in Europe. And before joining ADOC, I was a CEO of a company called Telemedicine Clinic, a pioneer in European teleradiology, where we actually evaluated and implemented AI solutions early on. So I do have a perspective both from the provider as well as from the supplier side on the topic of AI.
Wonderful. Thank you, Alex. Just a couple of final housekeeping points before we start. So just to let you know that the session is being recorded and the recording will be sent out in the next few days. Please feel free to share it with your colleagues. And of course, if you have any questions, please write them in the Q&A box and feel free to just write them as we go along, and we will aim to address them at the end. So with that, I'm delighted to hand over to Alex.
Yeah, so thank you, Nicola, for your kind introduction, and also to you, Professor Noppen, for your time and to be with us today to discuss the interesting topic, value contributions from enterprise-wide AI deployment in radiology and beyond from a CEO perspective. So before we dive into the discussion, I actually would like to introduce the concept of enterprise AI and value, also to provide a framework for our discussion. So, and to make it a little bit more interactive and to start with, and for learning control purposes, sorry, we don't give CME credits for this session, but anyhow, suggest we'll do a quick poll with the question of how our attendees are familiar with the term of enterprise AI solutions, and we will share the results afterwards. So, let me bring up then a couple of slides. Sharing the screen now. I hope you can see that. Okay, good. To frame the concept of enterprise AI, I wanted to start with a very brief overview on the development journey of ADOC. As hopefully many of you will know, ADOC is a leading provider in healthcare AI solutions. We have currently more than 20 CE-marked AI solutions on our AI OS platform, and our solutions are active in more than 1,000 institutions globally. And our journey, the journey of ADOC, actually began in 2016 with the development of own AI algorithms focused on imaging. In 2021, we continued our development in the area of care coordination, meaning basically that we started to provide imaging-based AI results to other physicians, like neurologists, cardiologists, ED physicians, addressing the issue of siloization of information within the hospital. So building on our CareCo solutions in 2022, we start to integrate non-image-based patient information like labs and vitals in order to assure the right information gets to the right physician at the right time. And then our most recent development also includes non-imaging AI solutions, basically to optimize clinical workflows and pathways. We call them patient management solutions, and they're specifically aimed at following up on patient treatment after the diagnostic process. So what has been the learning from this journey through AI so far? The learning was that basically value through AI can be created along the whole patient pathway, not only the diagnostic phase. So to understand our concept of enterprise AI better, let's have a little bit of a deeper look into the different components, which we also call the AI action layers. So at the core is our AI OS platform solution, which basically integrates and orchestrates both the ADOC internally developed AI algorithms, as well as the third-party algorithms, mainly for triaging, prioritization of critical pathologies. This was a steep learning curve for us. It was based on our experience of what it takes to develop own AI algorithms in a large number, and how to manage the challenges of workflow integration, image-based orchestration, and performance monitoring. From a healthcare provider perspective, it does make a lot of sense to consume AI through a functioning platform to reduce implementation efforts. But there are also significant performance differences between different platforms, a fact which I think is actually very little known today. As a next step, for us, it was to provide these AI results and other relevant clinical data, not only to the radiologist, but also to other physicians via mobile application, e.g. for neurologists, for the stroke solution, or the cardiologists for the PERT solution. The benefits are obvious: to include more stakeholders along the clinical pathway with relevant information at the right time in a convenient way to consume that information. Again, this helps to overcome siloization of traditional hospital information system. It helps to improve the team-based decision-making and can also reduce critical time to treatment. And if the value of the AI is perceived also in more departments, then the conversations with hospital management about AI adoption is getting even more convincing. So most recently, we have increased our development scope to non-image-based AI algorithms, basically to support workflows. For example, with our patient management solutions, where based on NLP and by integrating and reading relevant data from different sources like the radiology report, scheduling system, patient records, we help patient navigators to make sure that no patients fall through the crack along specific clinical pathways. So what is our vision for an enterprise AI solution? It's basically a concept which leverages the power of AI at all steps of the clinical pathway, from prediction over diagnosis, treatment, until patient management and follow-up. And that basically not only in imaging, but in all relevant specialties and based on the integration of all relevant modality data. So how does such a AI enterprise layer look from a technology architecture perspective? Well, it's basically like a middleware between the traditional siloed clinical information systems and the doctors, where different AI solutions run on one platform, which orchestrates and monitors data flow and lets different users use a broad range of algorithms through just one single user interface at different stages of the patient pathway. This is what we call enterprise AI. Now, after having discussed this concept, let's continue with value. And traditionally, the imaging department has been an early adopter of AI solutions. Given the existence of structured DICOM data, hence the immediate question about value contribution has been focused on efficiency gains for the radiologist, prioritization of urgent cases, quality improvement, and increased physician satisfaction in the radiology department. Yet many times the pure benefits of AI are not limited to the radiology department alone. As AI supports the timely and high quality diagnostics, significant parts of that value creation is actually happen beyond imaging in terms of reduced length of stay, decrease in readmissions, and improved patient outcomes, therefore impacting directly the profit and loss statement of the whole hospital. And these benefits can then turn into a cost and risk reduction of the whole healthcare system, even beyond the hospital. So this is what we call the value of investment in AI. So what is value? How can it be measured? So coming from the traditional value definition of patient outcomes divided by costs and maximizing that quotient, one relevant reference framework is the concept of the quadruple aim, which includes, apart from costs and patient experience and outcomes, also the provider experience and population health aspects. We believe that this can be a valid framework to identify and measure where AI can create value. So let's take a concrete example of the prioritization impact of AI downstream. So let's take an outpatient on anticoagulant medication who presents himself in the imaging department with headaches. He's scanned during the afternoon and put into a queue for reporting for the next day. When the radiologist picks up the case, he diagnoses an intracranial hemorrhage. The patient is called back from home, arrives at 11:10 in the emergency department where decompression surgery is done. Result, 11 days admission with a long-term neuro deficits in this example. With an AI solution, this case can be flagged immediately after the scan. The radiologist is informed and the patient is taken directly into the emergency room with a reduced length of stay of 2 days and no morbidity. So in this example, the prioritization effect of AI has an impact on at least 2 quadruple aim components: improved patient outcome and reduced costs. Let's have a look at a second example. And here we have an oncology outpatient, which is presenting with cough. He's scanned and reported falsely negative for pulmonary embolism. Patient continues for another 25 days with a PE until he presents again in the emergency department, now being diagnosed with a central PE and right heart strain. The patient is now intervened with a thrombolysis procedure and admitted for 5 days. With AI, this PE can be flagged already in the first scan and probably medicated with a reduced length of stay of, say, 3 days. Also, in this example, the quality assurance impact of AI has an impact on 2 quadruple aim components: improved patient outcome and patient experience. So, not surprisingly, there's an increasing evidence on the impact of AI, not only on the quality improvement and in reduction of patient turnaround time, but also in the reduction of length of stay. So I personally believe it's our joint responsibilities as vendors together with the providers to demonstrate that these values exist downstream along the patient pathway. So after this introduction to the concepts of enterprise AI and value contribution, I'm more than happy to hand over to Professor Marc Noppen for you to share your perspective from a practical experience point of view. Professor Noppen, over to you.
Okay, thank you, Alexander, for this first introductory slide deck. Coming from the perspective from the industry, as I may say so. So I would like to take the opportunity to share some slides as well, giving the viewpoints from, let's say, hospital management, and try to translate what you just said into, let's say, real life practice. So I would like to take the time for a few slides to see where a hospital-wide AI implementation can play a role, and why AI in general, I think, will be of foremost importance in the daily practice of healthcare. So I think there are 3 levels that we can look upon in a nutshell, very short, what I would call from system to component to patient. System is the healthcare system, which differs from country to country. And that is not without importance, as you will see later in my slides, in terms of reimbursement, who pays, etc. A second level would be, 1 level lower, would be the impact of AI in healthcare components, such as a hospital-wide application. And thirdly, on a more even lower level, on the patient level, the impact or the importance of AI now and in the future on the quality of care and outcome. And then we're going into the value creation element. Collectively, that's public health, but also personal healthcare, so which is not necessarily the same. Now, if we talk about value-based healthcare and creating value, I refer to the landmark paper which everybody knows by Michael Porter and Thomas Lee. And if you read the paper, actually, it's about two things. It's about integration of care, and it's about a prospective smart data management. Every value-based healthcare system has to be supported by a basement of, let's say, smart information technology. And if you look at what integration of care means, well, it's a whole bunch of things that has to be done. But you see in the middle that it has to be also in the architecture, the information logistics, as people call it, has to be in order. So this is on the first level of value-based healthcare. I think in general, data management, data science, artificial intelligence, and other, let's say, digital health tools will be of foremost importance. Now, going down one step into the level of the hospitals, what will be the role of AI? I'm talking now as a hospital manager, not as an MD. Well, what we have seen, for instance, during COVID is that when we are sitting on such a bunch of data, it's really incredible. They're all in silos, but during crisis, we had to combine all these data and put some smart algorithms on it in terms of capacity management. And so we created, let's say, a cockpit of the capacity management of the hospital, thanks to all the data integration and a layer of intelligence upon it. We are currently working on an automatization of medical coding in the hospital. You see, these are all administrative tasks, but which take a lot of resources, a lot of time, a lot of people. And these are the things that can help us in the current budgetary situation of many hospitals. And so we use our electronic patient record, Primus, as a base where we can integrate all these data. And even, cybersecurity is one of the main threats of hospitals. There have been a few hospitals in Belgium which have been attacked by hackers and in a ransomware situation, brought into a ransomware situation. But here also we use intelligence layers to detect out of the very many attacks on our system, which ones has to be tackled. And then even closer to the client, between brackets, is, for instance, the help desk of our IT system. We are now using large language models to investigate whether we can create smart support systems for our clients, internal clients, between brackets, of our system. So AI here is also already a tool which we use in the daily management of, let's say, the supportive mostly administrative functions in the hospitals. And I think it's necessary because the late Clayton Christensen 10 years ago already predicted that in order to survive, hospitals shall need to become more innovative, not only in their medical care stuff, which is our core business, but also in the management of hospitals. Now, the third layer is, what do we use today from AI tools in terms of patient care? Well, there are a lot of disciplines. Now, you of course are born into the imaging departments, but we use also AI tools, for instance, in cardiology, FFR calculation and treatment prediction of stenting or surgery. We use it in the OR, where we have algorithms running in certain surgical cases. We have an electronic health record since 40 years, so we have a bunch of data. And we use this information let's say, in a more predictive way. When we see a certain patient of a certain age in a certain indication for a certain surgery, using this and this and these drugs and having this and this lab results, the anesthesiologist gets a pop-up of saying, watch out, in 10 minutes, this patient's blood pressure will drop. So this is what we use already every day. In oncology, for instance, in the tumor contouring, which used to be manual, I, as a pulmonologist, have even done that in cases of lung cancer. I can still remember with a kind of a color pencil on photographs. So now, of course, we are supported by smart AI tools. And then one of your tools, for instance, the prioritization, what you mentioned in one of your cases, that out of the very, very many pictures that are taken from patients, the really urgent ones are picked out and really pushed towards the clinicians. But we also use it in dermatology, in the, every business where you have some image thing, like dermatology, or for instance, the image-guided surgery with augmented reality, where we fuse the MR images with the patient and an AR, augmented reality glasses for the surgeon to guide him into the surgery. In diabetes in children, for instance, we use an AI tool to support the monitoring and the data analysis, and then hence the therapy of kids with type 1 diabetes. And in pathology, for instance, also we are working on protocols to reduce the number of artifacts. So these are just some examples in clinical practice, which go beyond the purely medical imaging department and are used in a variety of disciplines. And this is important because many patients have not one disorder, but especially in the older population, you see they pass through various silos, cardiology, neurology, imaging, etc. So what you said there about the single user interface idea, and I'll come back to that, is one of the challenges I think we should solve together. During COVID, you see when there are crises, it can go quickly. We developed with a number of Belgian hospitals and companies an algorithm based on low-dose CT scan, because in the beginning of COVID, we didn't have enough lab capacity to do all the testing. And then this algorithm not only helped in the diagnosis, but also in the prognosis of patients entering ICU, predicting, let's say, a need for intubation within 48 hours in patients XYZ. So it can go quickly, fast, and you can gain value very quickly using these tools. In nursing, for instance, in our hospital, we use AI in the geriatric department, for instance, to detect patients who probably will fall out of their bed or stumble in their rooms, and thus preventing hip fractures and all the stuff that you don't want in your hospital, using really a smart algorithm and predicting what will happen in a patient who has a certain behavior. Of course, it's all anonymized, etc. But it's really a lot of instruments that we can use already today in a day-to-day practice in a hospital. And now going back to radiology, this is really what my chief radiology always tells me, that every 2 years or so, it's like the law of Moore. Huh? You have a doubling of the number of images that are taken in the hospital. And we have 40 FTEs radiologists, which is what we can afford as a hospital. But they have on average now 0.09 seconds per image. So there's two possibilities. There are too few radiologists, or we take too many pictures. And no, it's just the evolution of radiology. It's the last thing, of course, thanks to all the developments in imaging technology, rendering various types of images and image analysis in the number of patients, it has become simply impossible for radiologists to have a view on everything. So that is for me one of the main characteristics of the hugely fast evolution in imaging in medicine, is that it's coming beyond human capacity. And I think it's a no-brainer that we will have to use digital tools such as AI, especially in these kind of specialties. And so the top one there, the global shortage of radiologists, that's one element, but we will never have enough radiologists to look at all these images. So all the rest is secondary, in a sense that it's becoming simply impossible to run a current modern healthcare facility without the support of artificial intelligence. And there are many, there's not a single solution. I'm sorry to say, Alexander, it's not just ADOC that will help us. It's one of the elements in helping us. It's faster access. It's the vendors themselves who come with intelligence layers, but also a number of AI applications which are out there on the market. I think maybe we can have it in discussions. It's several hundreds of AI tools who have already their FDA approval for use. So there's a bunch of things out there that we can use. Now in our hospital, we work together since a number of years, and we have this agreement where we have the AI algorithms which help us in these domains. You have a number of other tools for the same patient in the same procedure, between brackets, where and that is a challenge, that we must be aware that the radiologist and the clinician is not drowned into the information that he gets and which is pushed. And so I come back to what you said about the single user interface, and the integration of the flow messaging in these patients will be of a paramount importance. So the role of the radiologist, if we compare, this is already a very old slide of 10 years ago, but very visionary. The role of the radiologist will change, or has changed already, and will change enormously further along in the future, in just the person who reads the images and then reports, and then somebody else will read this report and do something, as you mentioned very well in your flow description. The role of the radiologist will be much larger, and it will be supported by AI. So the new radiologist will play a role in deciding which type of imaging to do. And then at the end, he will play a key role in, let's say, a pivotal role in dispatching the information coming out of an examination to other clinicians, for instance, surgeons, radiologists, cardiologists, or whatever the discipline, or pulmonologist for pulmonary embolism, etc. So this is not only for radiologists. I'm still speaking as a hospital manager, so I have 41 medical departments. And there's a nice idea about which departments especially will change with the, let's say, the further evolution of AI tools. And that is important because we are a university hospital, we are a teaching hospital, and we have a medical faculty where there are young people who, for instance, wants to become a radiologist, but they will have to make that choice within 6 years, and then they will have to do another 6 years before they are a radiologist. That's 12 years. And if you look back 12 years ago, I think the discipline has changed completely. So it's another challenge that we face, is to how to guide our young doctors into these various disciplines and how to teach them, because it takes time, to change curricula, etc., and to teach young people that their discipline has become very different than maybe what their parents did as radiologists, to give an example. So we always use the baseline that AI will not replace radiologists, but it will replace radiologists who won't use AI. And that is I think the key message. And maybe you can extrapolate to all, or a number of medical disciplines. And I know that my chief radiologist, he likes this idea that he will be the last MD standing, because as one of the pioneers in using AI, he thinks he might become Dr. McCoy with this magical imaging tool who knows everything about the patient, and maybe that's of course a caricatural extrapolation, but he has a point. It's becoming more and more of another way of managing patients. Now, what I think is important, again, talking as a hospital responsible and manager, is that we are so overwhelmed with all the data initiatives that we see for the moment, be it AI in imaging, for instance, but also real-world data, analysis, etc. That we have to think really smart about making the right choices as a hospital manager. And I very like Halverson's statement here. If you don't have all the information for all the patients all the time, you are wasting your money. Because per definition, you are then working again or still in silos. Now, we are not there yet, to be honest, but I think that is the point at the horizon where we all should aim ourselves to. Now, how do we do this as a hospital? Well, it's always balancing. We don't have infinite resources. So we have on the left side the new initiatives of things that we might do with hospital data in improving healthcare, improving hospital efficiency, etc., creating value. That's what we're talking about. And what we call the offensive approach. And on the right-hand side, you see the real life. You have a number of limits, a number of hurdles, GDPR, data security, privacy, and all data quality, improving data quality, etc. So it's always balancing on this court. But we are convinced as a hospital that our data are an asset. They're not a liability. And we should really use it in a smart way to on these various fields, let's say hospital efficiency and patient care. That are the main things. And we have already take a lot of let's say made a lot of distance where we went from something with hindsight and retrospective and descriptive information to on the top right-hand side, going towards a predictive or prescriptive time where we can use the data that we have in real time and really predict what we should do in patient XYZ. And this is, you see, there's a number of tools and a number of concepts around this, but as a hospital, we are convinced that we should evolve towards this value, maturity, and scalability direction in order to survive, as Clayton Christensen said. And to conclude, well, every hospital, I think it's an international public, but I do think that, let's say, the healthcare budgets are under pressure in every country, I think. And if not, I would like to know in which country it's the case, and I will move. But every hospital is under a strict budget, in a strict budget system limitation. So it's not, we don't have endless resources. And if I look back, I'm in charge here since 2006. So I've seen the first, let's say, investments in machines, of course, but also in management, IT, etc. Then we have had in Belgium an accreditation wave for a few years that has cost a lot of money, and now we are really being put into this data management or data science environment, where we also have to invest. So that is then the responsibility of the hospital to try to create the circumstances and the framework where we can develop this and make significant improvements. Having said that, I think that's the end of my presentation, so open for the discussion.
Marc, so thank you very much for this excellent presentation, a very broad overview of the initiatives you are currently running. And I think it's fair to say you are definitely a front runner and a very early adopter of a broad range of AI solutions. So can you describe the main challenges you face today in the hospital and what you think AI can support you with specifically?
Yeah, it's not one thing. It's a combination of elements which are mainly due to the let's say the environment in which we have to work. On the first hand, we have a number of challenges coming towards us. We have a huge demographic evolution, at least I think in most of the Western countries who are present here. We have this demographic evolution towards an elderly population which will carry a number of chronic diseases. So the demand of care will increase. At the same time, we have a shortage or limitation of resources, people working in care, which also has to do indirectly with this demographic pyramid, which is upside down. But also for a number of reasons, there is a huge pressure on, let's say, the people factor in the hospital setting or in the healthcare setting in general. And the third element is that, yeah, you have also this technological evolution, medtech, pharma, etc., which has in general a higher cost and upfront higher cost. So if you put this together, and then some crisis that happens from time to time, some virus that comes along, a war that starts here and there, then you know, inflation, etc., the prices go up. So I don't have to explain you all of that. That means that if I look back since 2006 when I started, I had 2 or 3 years where everything was quiet on the Western Front and nothing happened, and we could really do our job. But there was always something. There was a financial crisis, a bank crisis, a terrorist attack, a virus, you know what. So these are some of the main challenges. But having said that, I think we have the responsibility also to make sure that what we are doing is sustainable, that we can continue offer the best possible care and cure for those who need it. And I think we will not be able to do this without the technical support, between brackets, of an augmented intelligence. I prefer augmented intelligence. I'm not so keen of the artificial thing, but it's just a supportive tool for the people that we currently have. And to conclude, my answer is you have to watch out, because a fool with a tool is still a fool. Eh? So it has to be used in a smart way, and that is probably one of the more complex challenges that we face as hospital managers.
Right. Absolutely. Yeah. So I think the fact that you have, as a digital, say, early adopter, the fact that you developed your own EHR system in early days, and also the role UZB played in the development of the PACS digital radiology solution, probably has been an early contributor to your early adoption. So how did that impact kind of your openness for technology, and how does it differ maybe also to other hospitals?
It surely helps, and it's symptomatic. You are absolutely right. Even the letter word PACS was invented here in this hospital, by the way. But having said that, that's symptomatic of, let's say, our role that we play as an academic institution, as a university hospital, because people who work here, by definition, they are interested in care, otherwise they wouldn't work here, but also in R&D, in research, in innovation, and it's a mindset. And we have had the luck that, especially in the radiology department, also in the IT department, where we had a visionary CIO at the time who really developed this idea of an integrated electronic healthcare record. That on the one side, so we have a lot of data where we are sitting on, and on the other hand, we have this radiology department who was one of the front runners in, let's say, go to the next level. And that is because I'm not an IT guy, I'm not an AI specialist, I'm just a simple pulmonologist and now running the hospital. But in our radiology department, we have a number of really smart entrepreneurial people who want to go further and who are keen on looking at or introducing new technologies. And I'm always happy when they knock at my door and I say, I've seen something incredible, you should see it, and I want this, and blah, blah, blah. So that is something of a luxury problem that I have, because sometimes I have to say no, unfortunately. No, I think it's a culture, and that helps me. And I'm sure that there are many other hospitals where you have this group of people who really want to go forward, and it's a ghost curve. Eh? You always have these forerunners, and hopefully they can pull along the ones who wait a little bit and to see what's happening. And at the tail, you don't want to have too many let's say, blocks on your leg, and who really. But then I'm a very lucky man, because we have a very, very, very good teams here at the hospital. So I mean, it's all about people. At bottom line, it's all about people.
Right. So there's really kind of this push and pull, no, in terms of from the bottom up, in terms of the need of individual specialists and initiatives which are coming out there, and then also the ability of the hospital management to define this AI strategy to really make it consistent, which I think is very impressive in your very specific example.
Yeah.
So now thinking,
sorry,
yeah, sure, please.
I would just like to add, and that is one of the difficulties, is that let's say the interoperability of all these systems within our electronic health record. So because we also offer our healthcare record to a number of other hospitals, so you have to maintain, and you have to have new versions and releases, etc. So every time you add on new interfaces and for new products, it adds to the complexity of the system. So we have to be very careful not to overload the system. So make the good choices, and try to find the good solutions which are interoperable and which have a very good user friendliness and user interface. Right. And that will be one of the main continuous challenges.
Which brings us to this discussion. I mean, there are more and more AI solutions available, and probably also the development speed of tools available will just increase. As of December 2023, I think we have 693 FDA cleared AI algorithms. The vast majority still in radiology, but also beyond that. And the main question will be how we'll be able to integrate these solutions, and what role will both platform technology play, but also change management within the hospital in order to really enable adoption, including validation, testing, and deployment at large scale. So this is a huge kind of task which is probably coming up.
Exactly. And when a few years ago we introduced in our EHR an alarm system, if you want, a decision support system in terms of medication interactions, to give you one example. But at the beginning, it was academically 100% correct, but it gave almost with every prescription a pop-up, because watch out, potassium is a little low or what have you. And that you have this pop-up fatigue at a certain moment, so you have to just provide the relevant information at the right time, and not every information all the time. What my last slide was, you have to collect all that information and have all that information, but you have to be very careful in prioritizing. It's a difficult word, and filtering the really important message that you want to give to the clinician, and not have the clinician drowned in a number of more irrelevant features. So we had to change that system in that because we saw that after a few weeks, everybody automatically popped away the pop-up, and didn't even look at the pop-up anymore, because okay, we know. So be very careful.
On that calibration, necessary calibration within the local environment and the necessary, of course. So you have a lot of partners, a lot of different providers. What has been your experience? What are the relevant criteria of selecting AI partners along your journey? How do you go about the choosing, implementing, and deploying of these solutions?
Well, first of all, I listen to the clinicians and the users. I'm not in the situation where I can tell I want ADOC for this and I want icometrics for that. And, I'm not the domain specialist. I have good people who are domain specialists. They do the first filtering and say, okay, that's one thing. Second, I have this, let's say this, our own digital platform and data people and EHR people who look for, is this, does this need coupling? Does this need interfacing? etc., etc. So they look at the more technical side of the matter. And then my third question is, okay, very nice, but and here we come to the subject of the matter. Does it create value? When my radiologist came with to mention ADOC, they came with some of the ADOC algorithms, and the question I ask, and our chief of radiology, which you know, will confirm this, that I ask him to keep track of, let's say, the outcomes, the results, the benefits that are created. And if there are none, we will stop it. You know, it's a methodology that we try to introduce, and that is my task, because I have to render to my board that all these very nice, expensive toys are useful, and improve patient outcome and doctor satisfaction, the user satisfaction. Because as I told you, it's in my opinion, if I saw those figures, it's impossible to do radiology without, except maybe, you know, if you do niche activity or something, if you're an echographist or something, whatever, or an interventional radiologist, even then. No, it's as you said, it's bottom up. It's a mixture on every level. But the main question comes from the user. We will never do the inverse. Maybe if I come across something that I say, this is interesting, I send it to the clinician, dermatologist, diabetologist, radiologist, whatever. If they say, no, we know this, blah, 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 it's not, we are not interested, then it stops. So we think that's the way to go.
Okay. Professor Noppen, maybe to conclude our chat, my concluding question would be, before we then invite our audience also to come up with questions from their side, what do you envision, what you want to achieve with AI in 3 to 5 years, say?
Well, in 3 to 5 years, I want, what I probably will see is an increase in the number of AI applications, also in other domains, not just the ones which I mentioned here, but there are other domains where we will probably see some new applications. For instance, in more preventive medicine and health preservation. To give one example, that is one of the things I will see. Secondly, I hope to see solutions for this more integrative platform approach of all the data coming towards the electronic health record and going towards the clinician. And that is, for me, I think one of the main challenges is this integration and selection of information and translating it into the flows, into the patient flows. And thirdly, and that is, from my point of view, it's not so much clinical as it is in the administrative and other logistical supportive departments of the hospital, where I think that a lot of, I would say, bureaucratic tasks or purely administrative tasks probably can be replaced by smart tools, smart digital tools. Let's say, for instance, the reporting, the letters, the admission notes, the voice-to-text solutions, things like that makes life easier for the clinicians and the nursing staff. Because I very well remember the paper written by Atul Gawande, Why Doctors Hate Their Computers. And I really want to avoid this. Doctors and nurses and patients, people who choose these kind of jobs, they have chosen these jobs for the end result, and that is to take care of people. And the digital aspect should be supportive and not replacive, you know, or a burden for the physicians. And if I'm very honest, we have a very developed EHR, but it still is, for a large part, a paper file in digital format. You know, there is very little intelligence coming out of it. And but we have support, decision support systems, etc. But it's still in the beginning. So in the next 3 to 5 years, I hope that there also we will see some improved intelligence, between brackets, coming out of all these data.
Excellent. So I think we can conclude that we do expect some significant evolution still here, and especially in this integration layer between EHR and the doctor, the consolidation and the ease of processing and consuming information and data. This is definitely something which we conclude and agree in as an important area of development. So thank you very much, Professor Noppen, for this conversation. I think it's a good moment to launch our second poll in order to get also some opinion from the audience with regards to value contributions. And then I think, Nicola, we are ready for taking some questions.
All right, poll should be up.
So the question is, what do you think is the most valuable contribution of enterprise AI? A couple of questions which or value contributions we've been discussing. Please make your votes.
We'll just give you a few seconds to do that. All right, I'm going to end that there. So Alex, you've got improving patient outcomes as your top result in that poll.
Yes. Thank you very much.
Wonderful. Okay, shall we have a couple of questions from the audience?
Please.
So some of the questions, Marc, that have come in, you have touched upon them a little bit already, but they're obviously points of interest. So could you talk a little bit around some of the legal challenges that maybe you faced when implementing such an AI system across your hospital?
Yeah, that's a question that I would like to transfer towards, let's say, the data management in general, not just AI in imaging, for instance, but let's say the use of the digital use of patient data. That is probably the underlying question. Well, here also we see typically in Europe quite a strong regulatory reflex. For instance, in our country, there has been the launch of a Belgian Health Data Authority, which is a government-driven agency which should supervise this question. And that translates into what every hospital, in our case, we have a data governance board, which we installed last year, and where we have a number of people sitting in this board, which is in our country, that is typically Belgian maybe. We have the head physician, which has the legal task of ensuring quality and patient safety and patient quality. We have the president of the ethics committee, we have the CIO there, and we have our data protection officer sitting there. We have our legal sitting there. And we have then the president who is also playing a role in this Belgian Health Data Authority. So there is a governance that we have installed to be sure that everything that we do is within the legal framework of our country and the future framework of Europe, because there will be probably coming out some new directives on patient data handling, if you want. But actually, that was the one slide I showed with the offensive and entrepreneurial part of the slide, and then the defense part of the slide, where you have to watch out that everything that you do is kosher. It can be done and is safe to do. But that is a good question. It's finding that equilibrium. And I must say, I think in Europe, we tend to be very careful and maybe a little bit overprotective, but that's my personal opinion.
Wonderful. Thank you very much, Marc. You talked a little bit about ROI at one point, but we do have a question about it. The question is, what are your hospital managers' criteria to select a new AI application, and how do you evaluate the ROI? So maybe you could just expand on that a little more.
Yeah, evaluating the ROI, that is not so easy. But I ask it with probably every when I get a question, a query of a department who wants to introduce a new AI tool. First, we look at the literature and see what has been proven yet or already with this application. But we usually don't find a lot, and what we find is not necessarily applicable in the Belgian system of reimbursements, etc., because that depends on the country and the system where you work in. So the financial ROI, that is more, let's say, that is our stuff, that we will solve that within the Belgian framework. What is most important is the return on value, on outcome for the patient, but also for the caretaker. And there we, for instance, in radiology, there are every year master students who have to make an academic master thesis to become to get their grade. And instead of doing the typical study of the literature, blah blah blah, of this or that, we ask them, or we give them an assignment. Look, we have now this new application. Let's say to talk about something completely else. The detection of melanoma using an AI-powered skin machine. Okay, give me the results. What do you expect? What is the number to treat? What is the cost to treat? What are the relevant outcomes? So in most cases, we make a business case analysis financially and also in terms of outcome. And sometimes we don't have the data, and then I have to believe, between brackets, my clinician who says, I really want to do that, and I have good foresights that it will add value. Luckily, as I said, we have excellent people, and usually they are correct. But if they do this 2 or 3 times, and 2 or 3 times it gives not the expected answer, then the next time we will be very, very careful. But it's on the, it's how do you call this? It's learning on the run, it's case by case and really learning on the run.
Wonderful. Well, I think we are actually at time, so we'll have to wrap it up here. But I'd like to just give a huge thank you to our speakers, Marc and Alex, for addressing such an interesting and thought-provoking topic. We still actually have questions that we haven't managed to answer, so we'll try and get the answers out to you after this. If you'd like to discuss any of these topics further, then we will be at ECR at the end of the month. There'll be an email sent out afterwards with the recording, and you can book a personal meeting with the ADOC team if you would like to. And finally, our next webinar is February 14th. It's going to be about healthcare in the age of AI, how memorial healthcare is bridging the gap between theory and practice. And that's going to be with ADOC's CEO, Alad Wallach, and healthcare leaders from Memorial Healthcare. So thanks everyone again for joining, and we hope to see you soon.
Thank you.
Thank you.